Hey, this is John Lee Dumas of EO Fire, and you're listening to The Ultimate Doctor. Check out all the great interviews with medical geniuses about the future of healthcare.
I've been looking forward to speaking for a while with Dr. Shami Gupta, who is here with us. Great to see you.
Thank you. Thank you for inviting me.
And welcome to the show. Can you go ahead and just start out by telling us a little bit about yourself, where you are, what you do on a day-to-day basis?
Yeah, sure. I'm a nephrologist, so I'm a kidney specialist. I trained down here in Louisiana. I went to undergrad at Southwestern Louisiana, now University of Louisiana Lafayette, and started med school in 1994. Graduated from Louisiana State University, New Orleans, 1998. Spent 3 years as an internal medicine resident in the same program at the former Charity Hospital of New Orleans. A year as the chief resident, and then 2 years training to become a nephrologist. So I'm a specialist in kidney diseases. And I've been in practice now for, 11 years, all here in southern Louisiana, and I work in a small town called Houma, which is south of New Orleans, actually. And most people don't know there are cities south of New Orleans, but
right.
there are. So that's been my love. I practice in the public sector in general. And I do a little bit of private also now, but I start off in the public sector and now have a hybrid practice where I teach residents and students, but I also am involved in my own dialysis centers and in the private sector in that way.
Well, yeah, that's quite a journey, and you still remember all the steps extremely well. I imagine it could be easy to get lost in the midst of that or feel like large segments of it were missing. But you emerged on the other side. You said 11 years now you've been in practice, so for any of the readers, there are lots of students at different stages, pre-med, medical students listening to this podcast. Can you explain what you mean by you largely work in the public sector and the different types of what your practice involves with dialysis?
Sure. So in terms of public and private, basically what that means is I've stayed in a teaching hospital. So I'm part of a faculty affiliated with both Louisiana State University and Tulane. The hospital I work in has students that come from actually Caribbean medical schools in general, but also I interact with students from LSU and Tulane. And basically, I'm one hospital based. So, for example, in the morning, I go and I take care of patients in the public hospital setting, which are all charity hospital type patients. Some are uninsured or underinsured. And this is called a safety net hospital. So we have a team of physicians there, and we have teams of physicians with a staff physician, resident physicians, and then medical students. And kind of like you see on television. So if you imagine, for my generation, it would be ER. From the current generation, it might be House or Grey's Anatomy or something like that.
On the other side of my room here, I've got a House poster.
So that's one of my jobs, and that's what I really enjoy doing. But it allowed me, because I was in a small town, to branch out where there was a big need for dialysis. So dialysis is kidney care or kidney support. And because I had some flexibility with my schedule and my job, I was able to venture into that world where I also take care of the same patient population, but it's separate from the hospital system that I work in. So I get a little bit of both. So I enjoy the teaching aspect and the rounding aspect from the teaching hospital, but I also have put my, so to speak, more than my foot in the water now. I started 5 years ago with a dialysis center in a small town, and which has grown now to take care of a pretty large group of patients. And I specifically focus on home-based dialysis. So in rural markets where patients have difficulty with transportation, money, and those sorts of things, home-based dialysis really serves the needs of my community there in a very positive way. So I never thought I'd be doing that, frankly, this whole journey. But I ended up there really. I live in New Orleans, but I work down in this little small town because of Hurricane Katrina. So when the hurricane came in 2005, I just finished my training and was opening my own practice, and both the hospitals I worked in flooded. So I was left unemployed pretty quickly. And I used to work in this small hospital about an hour from my house when I was a resident moonlighting, trying to make a little extra money. So I approached them, but they needed help full time, and that's how I kind of ended up there. Never thinking I'd be there for 10 years and building my whole career there, but because I really enjoy it, and it kind of worked out. So silver lining to the hurricane for me was having this new opportunity posed to me, which I'm really thankful for these days.
That's a great way to put it. And Shami, that's actually a great segue into the next question. There are several things you said there that I want to touch on to make sure people get a good sense of it, especially because the main areas we're trying to focus on in this podcast, a lot of the questions that students have at, high school, college, or medical school phase, planning to be future doctors, is about each of those steps in education, and then the business side of medicine, how they get into that, and then the innovation, obviously. Right. But I wanted to start with that. It seems like you have a very real sense of place and are somewhat rooted to an area, and obviously that was influenced by the hurricane. But compared to a lot of your maybe friends and colleagues in medical school and residency who were, on one coast this year and then 2 years later on another coast, do you feel like you've had a very different experience?
I do. I was born and raised in Louisiana. I've stayed here. Now, in retrospect, I may have gone away for a couple of years to train somewhere else and come back, but I always wanted to practice here in this environment. And I think it is very important to, no matter how you go through this journey, is that you have to be somewhere that you enjoy being. Unfortunately, I think a lot of students and residents imagine their life as a doctor, but they don't really take into consideration where they're going to live, the cost of living in those places, and really how their personality fits into those places. So a lot of my colleagues are practicing physicians and doing fine and have good jobs and good lives, but I don't know if they're doing exactly what they want to do in the way they want to do it. So I think that's one of the pitfalls sometimes in this journey, is that thinking just finishing your training is enough. But you have a whole life after training that's actually you're going to spend more time in your life after training than training.
You're really just learning how to learn, right?
Right, and it's very important to take into consideration, your family life and what you really want out of life, and how that's going to change over time. So for me, living in New Orleans but working in a rural environment really kind of serves my lifestyle pretty well, in the sense that I have that satisfaction of working in a small town, small environment, but I also have the ability to come back to my house every night and enjoy a relatively an urban place. And so I didn't, again, that kind of happened by accident, but now as I look back, I feel very thankful that I've been able to discover that along the way and have the rural environment has afforded me the opportunity to do other things that some of my colleagues in the urban environment can't do. So, for example, because I'm one of only a few kidney specialists in that region, the hospital works with me a lot more on what I want to do as opposed to telling me what I have to do. And, as long as we have that understanding, it works out well for both of us. So, I never realized that going into all this, but the hospital is happy that someone's coming there every day. And in exchange of that, I said I'd like to have some flexibility in my schedule to do other things that I want to do. And they have afforded me that opportunity. Hence, I'm able to do some of the private things that I do without some of the restrictions that other people might have.
Yeah, that's a fantastic insight, actually. So, real quick, while we're on that part of it, can you tell us a little bit more what that negotiation looked like, or why they were open to an arrangement like that? Did you just show up at their office one day and say, this is what I want in a contract?
Well, that's a good question. So basically, in the world of my specific specialty, kidney care, there's lots of different components. And one of those things is the ability to work in the private sector, in the private world of dialysis. And, I didn't know much about it other than that's an opportunity. So after the hurricane, when I went down to talk to the hospital, I told them up front that I really would love to be here, but I need to have the ability to do what I want to do on the side. So what that means is when you work in a public hospital, they're going to provide any hospital. They're going to provide all those things you need to practice: the office space, the malpractice insurance, because they're taking the risk on you. Mm-hmm. But when you go into business for yourself, you assume those risks. So part of the stipulation, it wasn't that easy. I said I'd like to do that. They said you can do that. But as long as you fulfill your requirements here, but you must maintain your own separate practice and office and malpractice. So there are a lot of costs associated with that. But if you see potential in that, it's worth the investment. So my plan all along was just to kind of have a 50-50 sort of thing. It took me 5 to 6 years, though, to get to a point where I was actually breaking even on my cost side.
Okay.
Only in the last 3 or 4 years has it become much more economically viable for me to do this, because it takes that long to build any sort of business or practice.
Absolutely. And that's definitely worth discussing. Before we get into maybe some of the nitty-gritty details on that, you mentioned the word risk at least a couple of times, and then malpractice. What was it like, or what was the biggest motivation to basically, emerge from all your medical training? You're in a very risk-averse environment, both for the sake of types of patient care always mitigating risk when, for complications and infection and all these hospital procedures they have now for mitigating risk, and just risk averse in the sense of, insurance companies are set up a certain way to make sure doctors never take certain types of risk. What motivated you to get into something that would be a little risky and maybe not make any money for a while?
Well, I think as you go through this journey of medicine, you realize that as educated as you are, you end up being an employee of a hospital system. So you really don't control the chips at that level. And as you get more experience, you realize that you actually do have a lot of, you have some clout and some power, because the physician and the team that works with them really is what drives the economics of a hospital, okay, or the economics of anything. Because a lot of physicians ordering something or taking care of a patient, there's no money flowing into a hospital. So hospital administrators realize that, and as long as you're part of the community and a good citizen and participating and doing what you need to do to take care, if you're taking care of patients properly, then all the other stuff falls into place. But the lessons I learned from the hurricane and never realizing that a doctor could become unemployed. That's one of those things about being a doctor, is you're always employable.
Right.
And you get a job, but when your hospital goes underwater overnight, you don't have a job because there's no building to work in. So I learned from that lesson as I built my new practice. I tried to build in some redundancies in case something closed, something got shifted, something didn't work out, my boss changed and didn't want me to do this anymore. I needed to have something so that I could live the way I wanted to live, as opposed to being captive at the hospital and saying I have too much to lose by leaving. So, for example, if you leave, you have to move your family. If you leave, your kids have to change schools. If you leave, so I see a lot of my colleagues who are trapped in these worlds where they become lifestyle dependent on a geography, and it's difficult to really relocate as a physician. So I wanted to have that ability that now I do. Those first few years I didn't have that, because had something gone not well, I would have had the infrastructure to go on my own. But I do now. So God forbid something were to happen in my hospital, or changed ownership, or got bought out by another hospital, or something like that, I still have this practice that I've built now that I own. It's my practice. And I could at least take that with me wherever I go, or use that as a tool to still open up with a new hospital or something like that. So when you're in practice, that's all you can really build, is those relationships with your patients,
right,
and that goodwill in the community, and that's what you own. You don't own any patients, but you own the practice, and that's what you're working every day to build.
Yeah, wow. Did you have any business training before this, or was it literally just an epiphany moment of, wow, I just saw a hospital go underwater and hundreds of my colleagues are without a job now, we have to go elsewhere, and you just decided to jump into it?
A little bit of both. No business training. I was a straight biology major in college, and I really developed a love for nephrology because it's a really numbers-based specialty. I love that part of it. And I knew a little bit about the business side just from, how you see things and you see other people, and very, snippets of it, but not the actual side of it. And, my father is a retired physician and a restaurant owner now, and he's always had that business sense. So a very general business sense, but not a in-depth business training of any kind. Mm-hmm. I just realized that I didn't want to be working for someone else only. That was really my only motivating force in all of this, because I felt so, when the hurricane happened, for example, we just had our second child. So basically I went and I just bought a new home based on my training.
Okay.
So all of a sudden, that fear was palpable for me, and I said, I just cannot have that feeling again. And that's what really drove me to learn about it a little bit. And again, I think it was circumstances. I couldn't have asked for that arrangement without going to a small place.
So both for the lifestyle security and the sake of your family, and I imagine the entire area was in turmoil at that point. So you're just looking for another route to potentially take care of something in the meantime.
But also, I had mentors too. I'd seen some of my colleagues ahead of me who didn't take the traditional route of joining a established practice, going out on a limb, opening their own shop, who were 3 or 4 years ahead of me in training. And I really admired how they were able to do that. So I sought out some counsel from them. And so, I'm thinking about doing this. What do you think? And invariably, anybody who's done it will say always said the same thing. It was scary at first, but best decision I ever made.
Yeah.
So
who's been the best mentor so far with that?
I have a colleague of mine who's a general internal medicine physician, and his name is David Myers. And we're not the best of. We're very close. We're friends. But we weren't like friends in training and that sort of business. But after he finished, we were in the same program, and I reached out to him as I was in the same program you were. I really like what you've done. Can you kind of share some of the insight with me? I have another friend of mine who was a gastroenterologist, did the same thing. So I just kind of asked around a little bit, and I think not even one person hesitated and said, I wish I would have stayed with where I was. They all had gone into practice for different reasons, and now they're all independent and successful and really are movers and shakers driving what happens. Because once you do that, then people look at you as, look at that guy, he went out on his own. Maybe we should put him in a leadership position in the hospital. Or maybe we should ask him to do this. So this sort of it's created more opportunities for me as a respected physician in the community because I'm on my own. Now, there are struggles with that, but when people look at you, they say, wow, somebody's open. They've done it on their own. Why'd they do it? Just like you're asking me, why'd they do it? How'd they do it? And I want to do that too, maybe. Or you collaborate with people who are also doing the same thing, which makes for more than you with like-minded people all the time. So then two people who are interested in being on their own are working together now, and then it becomes exponential. Then you meet other people, and you have this own little subcommittee of people or a little sub-community of people who are all independent but dependent on each other. Like they're saying, okay, so from example, my friend, Dr. Myers, if he goes out of town, I cover for him now. I can help him. And we have that kind of relationship now where I help him out and vice versa. Even though we don't always go out together, but we can cross-cover each other and respect each other at that practice level. So that's something I've found as a pleasant surprise along the way, that it gives you instant credibility if you can do something on your own.
It sounds like you leverage your community incredibly well too. So I'm sure that was appreciated, as you said, within the hospital infrastructure. It's not just people think of a hospital as one building and they assume everyone there is on the same page, but there are lots of different little subcultures that can emerge.
No, for example, I'll give you a real example. There's committees at hospitals. So those committees are all chaired by physicians. So not everybody has to do that, but that's a way to give back to your hospital or your community by saying, I'll chair a certain committee or whatever they ask you to do. Chairing those committees also gives you a lot of insight on how hospitals work so that you're on the same page as administration and your other colleagues so that you can make that hospital survive as a business. It's a place to take care of patients, but ultimately it's a business operation that has to be run efficiently and well. And if you're just a third-party physician not participating, then you don't really have any skin in the game to know. So when you participate at that level, it also gives you an insight to how other people work, other people's points of view, and learning how you can really be a good community member in that hospital. Like you said it better than me. These subcultures, sub-communities within the hospital. Some doctors don't do anything. Show up, go home. That's fine. There's nothing wrong with that. But the ones who do participate do get extra benefits in the sense of those relationships they can build. Mm-hmm. And maybe a little, just that connection with your colleague is much greater at an administrative level. And you know what people are going through every day then.
All right. So if you would, take us back. Let's rewind about 11 years here. You're emerging from several decades of training. You've got medical school under your belt. Now you're Dr. Gupta, and you go through residency. You get your super specializing fellowship, and then Hurricane Katrina happens, and you decide to launch out on this business venture. So maybe take us through the first few months, or what you remember, just the day-to-day. Did you suddenly have to teach yourself marketing, sales, patient recruitment, all these different things, and what did that look like?
Good question. So as you can imagine, you and I are Skyping right now. 10 years ago, this was not a common occurrence. So even in the last decade, the advancement of technology has been so huge that someone like me is kind of on the fence of both. I learned in an environment really internet-based, still very book-based and those sort of things. So I had that was my skill set. So when I went out on my own, I didn't really have the advantage or the benefits of interacting quickly and easily. So it was a very traditional model of incorporating on the phone. For example, calling 1-800-IRS and getting a tax ID number that way. Okay.
Yeah. Wow. I don't think it's that easy anymore, but good to know.
Kind of stuff. Instead of doing it online, having to call and wait on, getting it done that way. And then all of a sudden, I don't think the business side comes after. You just have to jump in and start seeing patients. Getting an office space, for example. So my first office space I shared with a colleague of mine. I asked if I could rent his existing office space 2 days a week.
Okay.
He already had a receptionist. He already had everything in place. So I didn't have the money to go and get in my own office. So I actually worked in a hospital part-time as a hospitalist where I had a salaried position. And out of that practice, I would get my own referrals for kidney disease. And I'd have office hours on my off days. And I would rent an office by the day, basically. So kind of what you hear on the radio now, these virtual offers that are set up. I went to one of my friends who was already out in practice, and I said, I'll share a call with you guys if you allow me to use the office 2 days a week, and I'll pay a rent of whatever you think is fair. So I drove my costs down from whatever the standard rates were to probably about a third of that in exchange for getting in their call schedule with them.
Okay.
So I was using some tools there to minimize my upfront costs by paying with my time. And the more I spent time in the hospital, the more people got to know you and the more patients you got. So for example, at night in a hospital, they have a hard time finding. Older physicians are required to take call at night as part of being part of the medical staff for patients who come in who are unassigned. So I went to the medical staff office and said, anybody who doesn't want to take their call at night, I'll take it because I want to build my practice.
Got it.
And the older physicians don't really want to take that call anyway. So now all of a sudden it's off their plate, but I have the opportunity now to meet more physicians and get in the hospital. So for the first year was very scary, and for the first 4 to 5 years I continued to do those kinds of models, where even though I was a nephrologist, I was still doing hospital-based care, working on weekends, working on nights, to make enough extra money to pay off my expenses, which weren't being offset yet by my other practice. So that period of time took about 60 months before I got to a point where I had enough dialysis practice to break even on my costs.
Yeah, you can still count the months for sure. It sounds like you continued the trajectory. You mentioned moonlighting during residency.
Correct.
And you basically used that ability to be able to, split your schedule certain ways. You kind of knew
Correct.
the process and were able to get in with this colleague who, you said he basically had 2 offices at the time?
These are 2 different folks, but basically I would utilize some of my friends who were already ahead of me in training, and I knew them well enough from training days that I would say, what day do you have a half a day that's empty in your office where you're not using it? But they still have rent. Their costs are the same because they have to pay for the whole month, and they have staff there, but they don't have patients there. They may be an administrative day for them. So if you give me one of your 3 rooms to use that day and the use of your staff, you can prorate it for me, and I'll pay for that day, as opposed to me having all the overhead of all these practice of a normal practice. Because my goal was to build the dialysis side, but I was seeing patients in an effort to generate income and to generate goodwill and see patients. And now my colleague who I'm sharing call with, who's a general physician, when he has a kidney case, he's sending it to me because I'm in his rotation now. So I was trying to build relationships in that way without knowing all the people I'm dealing with, but in an effort to say, I'm going on my own. Here's my card. Call anytime. I don't really care what the what the insurance of the patient is. Let me just get busy. And now over time it took a long time, and I didn't know if it would happen, but it finally happened. And now I do purely nephrology in my little town, but I still work on the hospital wards like a traditional physician, seeing patients with residents and students, because I really grew to love that as I was building this. So my practice is kind of half and half in that way. So in the morning, I still see patients every morning with a team, just like on the TV shows, where the teams have seen the patient. We sit at a table, we talk about the cases, and they're all general cases. I also do the kidney care for the hospital because I learned to like that a lot and love it actually as I went through this long process of building my other practice. I never thought I'd be doing both long term.
Sure, yeah.
So that's kind of how it all worked out in the end.
Can you give us a sense of how quickly that scaled up? You said one of your top priorities was, recruiting patients, being there consistently so they could trust you. So after 1 year and then after 5 years, how many did you have? And were you seeing each of them several times a year with continuity of care?
So in terms of dialysis care, the patients are in a dialysis center. So I'll walk you through real quick. A patient gets referred to in the clinic who has some abnormalities of the kidney. They may have mild to moderate. Most of those patients will never end up with complete kidney failure, okay? Depending on how many you're seeing. A small percentage will. Those are the patients that become part of this practice that I now, which is now separate from the hospital that I work in, okay? And those patients I see once a week on average in the dialysis center. So when I started in 2005, I had 0 patients. By 2008, I probably had about 15 to 16. 2011, when I had the opportunity to open my own center, I was up to 40. And then now between 2011 and 2016, I'm at about 95 patients. So the curve goes up much more rapidly later, like anything. But those first few years are challenging because you have to have enough cohort of referrals and be available all the time so that you don't miss referrals and see. So you're seeing hundreds of patients for every one patient that actually ends up in a dialysis center, which is a good thing. It means we're preventing a lot of disease. But invariably, some people progress. So those who have progressed become part of that practice that I take care of independently from the hospital that I work in.
Wow. And so what type of time commitment, now that it sounds like it doubled in about the past 5 years, so you go from 40 to over 80, 90 patients. What kind of time commitment is that for you on a weekly basis now? And have you started to build it in different places, hired some staff to help with that?
So I've partnered with a dialysis company to open a center in Houma, Louisiana, and a second one now in near New Orleans. So basically it's part of the work day. So I'll walk you through a work day. I'll leave my house about 7:15, 7:30 in the morning. I work an hour away from my home. So I drive 55 miles south every day through Bayou country. For some of the people listening, if they remember the BP oil spill from 5 years ago,
right.
That's where I work now, the epicenter of the BP oil spill. And I drive there. I reach there about 8:30, 8:45. I go to the hospital floor where I round with my medical team, just like I keep mentioning the TV shows, just like that. We see between 8 and 10 patients on the floor and teach from 9 to 11. 11 to 12, there's a morning conference where we present patients and hear the cases as teaching physicians. And the afternoon is spent in the clinic or in the dialysis center, depending on the day of the week. So 3 days a week, I spend time in a traditional clinic where I see patients about 15 to 18 in an afternoon. The other 2 days and other days, I spend time going to the dialysis center to see patients while they're on their shifts. So patients are either on a Monday, Wednesday, Friday schedule, morning or afternoon, or Tuesday, Thursday, Saturday. So I try to squeeze in seeing everybody at least once a week.
Okay.
So a lot of back and forth. So the workday is still kind of a 7:30 to 5:30 workday, but each day is a little bit different in where I'm going and who I'm seeing, and I kind of try to get the work done in that time frame. So that's basically my general schedule now, and because I work in a teaching hospital, my call is I still take call, but because I have trainees in the hospital, just like in the traditional model, they're the ones who are seeing the patients and calling you with any problems. So I don't have to go in after hours too often anymore. That's the last. But the first 4 or 5 years, I was working lots of nights, other places, as I alluded to earlier. So that's kind of the general work day. And for me, I'm married. I have 2 children. My children are 14 and 11 now. So awesome. I need to have the time with them now. I didn't think when they were younger, it was easier to work weekends and nights because they were sleeping in babies. But now they're young people who we can all do stuff together. So I've tried to structure my schedule so that I'm home on the weekends when they're around and when they're not busy, so that we can have time with them.
Absolutely. And again, very kind of you to take this time. I know it's late, definitely your time and my time, but I appreciate you taking that while being a great family man.
No, and I think that's something that's lost to the listeners of the podcast, is that's part of also your job. Your job is to be a doctor or whatever your career is going to be, but it's also very important to remember that your home life is very, very important to incorporate into that. Not necessarily every day, but if you average it out over a week, a month, a year, there are certain periods of your life you're going to work very, very hard so that you can have time later. Just like anybody in school or in law school or med school or any professional school, they're working hard so later on they can have a better life. And the same thing applies to medicine. Just because you get your degree and your fellowship and your residency doesn't mean you're done. You're kind of starting over again now. Mm-hmm. And you have to build your life and your career so that you can enjoy your life and career the way you want to, and don't become a slave to your work, where you feel that you have to go to work to support the lifestyle. It should be the other way around. Yeah. That you're enjoying your work. That's very important.
We mentioned one of the themes overarching would be innovation that we want to discuss. And you mentioned how, and I think 100% of entrepreneurs would agree with you, that basically the first 4 or 5 years are spent running around, putting out fires, fixing problems, dealing with things you couldn't even foresee when you initially got going with the process. So that's mostly playing defense. Now that, a lot of this is, largely under your belt, you have maybe time to think on that 55-minute commute. Do you feel like you're able to be creative at all in your practice or to go on the offense? And how are you starting to incorporate some innovation into your practice?
Good question. So, that drive is very fun because you have a lot of time to yourself to think about things, and it really is quite therapeutic. But I do a lot of lectures. So I teach students and residents every day, part of my job, and I've learned I do a lot of mini lectures. So I spawned off one idea I've been working on now is I have a YouTube channel where I've created lectures there through a program, Prezi, which you probably are familiar with. Mm-hmm. And so instead of me giving the lectures all the time, I've created a channel of 7 to 10 lectures on a YouTube channel, which I'm hoping the next step would be to take that to another level where it'd be more open to other medical students and residents, not just mine. So I'm working on that. That's a small project I'm working on now because I'm very passionate about that one aspect of education. I also have I do a lot of home-based dialysis. So for those not familiar with that, there's traditional dialysis in a dialysis center, and there's dialysis at home. So my practice focuses more on home-based dialysis than the traditional dialysis. So those patients I was mentioning to you, those 90 patients, nearly half are at home. So those patients I see either in the home, their own home, or I see them in the dialysis center only once a month. So I'm trying to grow that part of my practice through education, innovative techniques in education, either through the web, through videos. So the same YouTube channel I have patient videos that I've created with the help of a little team that I show to patients. So I've kind of branched off in a little bit of online and video making, which I really enjoy. I enjoyed that as a young person, but never had the technology to do it or knew how to do it. And now with the advent of all these interesting things that we have, I'm trying to branch off into that world and do that. So that's kind of what my passions are. And I'd love to take it to another level where I could share that with other students and residents. Because right now we're all reinventing the wheel every day.
Right.
Everybody's way everywhere, and that'd be a nice tool to have a central resource that you can go to. And that's kind of what I like to do. So.
Yeah, you touched on several great things. Essentially, a doctor is a finite resource. Just one human being can only be so many places at once. And you mentioned you see 15 to 18 patients in an afternoon. Well,
right.
Obviously, if you create a video curriculum that patients can engage with more often from the home when you can't travel out that direction, care can drastically improve. So you said you've got about 7 to 10 videos so far, and what would you like to expand with that, and what would be the next project?
The next project would be to probably try to get other people who could create similar videos and post it on a central channel. Not, the internet is awash with videos, and if you go there, look up anything, you'll find thousands of videos. To me, I think the modern student, the modern professional student, doesn't have a lot of time, and to put things down to 4 to 5 minutes is what I'd like to do. Create a channel that has videos that are no longer than 4 to 5 minutes, capturing the salient features of a complicated topic. Because everybody has the books and things they can read. So it's not meant to replace the book, but it's meant to be that professor in your pocket, so to speak, that, who's giving you those snippets that you just need to help you connect those dots. So on my channel, it's on YouTube called the Renal Whisperer. And on that channel, we have 7 to 5 minute videos that talk about very complicated nephrology topics. Try to break them down into bite-sized pieces for a student who's already been reading or a student who's already seen a patient. I may have heard a long lecture, and they just couldn't remember all the details. They come back and learn it in small bites. So I like to find other people who can lecture in the same format and maybe create another little mini world where someone who learns the way I learn would go to that channel and learn that way. Because it's not for everyone, but someone who learns in that way might be able to have a new resource. I find things that are too long or hard to process, and people end up fast forwarding through them anyway. So it's not really meaningful. But if someone gives you a 3.5, 4 minute video, I could watch that. Especially if it's good. If it's engaging, you will watch the whole thing. So that's been my thing, kind of this 5 minute, no more than 5 minutes.
And if it has a great name, which tells you the author has a great personality, obviously. I'm curious, what was the inspiration for picking the Renal Whisperer?
I'll tell you, one of my students coined it. I make jokes all the time because my wife and family thinks it's kind of a silly name. But one of my favorite students, he's the one who coined. I was giving a lecture in class, and I overheard him. He actually said that to one of his classmates next to him. I love these lectures, just like hearing the Renal Whisperer. So I kind of stole it from him because I heard him say that in the front, and I've given him credit for that. As I've seen him, I said, "You spawned off the name of the channel." So I've debated about changing it, but I think it's catchy enough and controversial enough that if you don't like it, you might still go check it out. So if people don't like the channel, they may still go listen to it just because the name may draw you in.
Absolutely. We'll make sure on the show notes to link to that so everyone can go check out the new and any upcoming videos.
Yeah.
So speaking of projects that are developing and stuff that's coming out, in terms of the technology, I guess another aspect of medicine that people are still trying to wrap their heads around, insurance companies are trying to understand, Silicon Valley companies are innovating, is with the idea of, like you said, book or doctor in your pocket. So telemedicine companies like Doctor on Demand.
Right.
Is this going to come into your dialysis space at all? Is that something you've thought about getting into? And do you think there's any loss of quality of care with that happen? So about 2 years out from now, where do you think that'll be?
Well, I think the government regulations are all that's holding us back here. I think many physicians, almost all, would agree that many of these encounters can occur just like we're having our meeting right now. It's about seeing the patient and talking to the patient more than actually touching the patient in some instances. For example, my home-based patients, some live very far away, 30, 40, 50 miles, and still come in only once a month. But that would be an ideal visit to do through telemedicine. But right now, the rules and regulations of of Medicare, other places, are on a case-by-case basis. It's not so universally accepted. So I think a couple of years from now, it's going to happen as we get fewer and fewer doctors out there in these rural places. And I think it'll happen in rural America first because there's there's fewer physicians and there's a lot of sick patients. And those patients also often have limited resources in terms of finances, economics, and driving and gas and all these other things. But those may be the places that it's piloted first. So in the dialysis world, it's ideal to do this. We have not done it in a meaningful way yet because the regulations of dialysis really do not permit us to do this effectively yet. But I know there's a lot of legislation being pushed through from advocacy groups, the National Kidney Foundation, Renal Physicians Association. It's a front burner item, and every year they get a little closer. So I'm hopeful that by the next couple of years we will be able to do this. But it's not for every patient. But I think on a selective level, it certainly could be applied to many of the patients, particularly in dialysis. I could imagine a camera on a chair, like on a dialysis chair, on the patient directly, and they could press a button like a Skype button, and they could have a problem, and I could be somewhere else, and we could talk just like this in 2 seconds and show me whatever's bothering them, or just have a conversation, and then connect to the electronic medical record, send off a prescription, very, very quickly and easily. Right now, there's simply no way to, from the financial side again, there's no code, period, for a home telemedicine visit. So the physician who does this right now is doing the same thing they'd be doing in person, but they're not recouping they're not getting compensated for it at all. And unfortunately, that is the business side of it. So until that catches up, it's going to be hard pressed for practices to put money down or put things in place to make it, it has to be incentivized. And one of the things you were asking about was the incentivization of that would change medicine dramatically. Particularly rural medicine.
I'm glad you mentioned that because in our email correspondence before this, not many people are able to keep up with everything changing in CMS, Medicare, Medicaid. And you mentioned that especially because you're running a large part of this clinical practice, you have to stay on top of it. So with all those changes in the past 2 years, what is the biggest area you see? What would you prioritize if you were suddenly in charge, named Secretary of HHS? What do you think should be addressed right away?
So in terms of innovation, I think this would be a priority one. Telemedicine, the ability, or using technology to even touch the patient through telemedicine. I know there's devices now, for example, through the iPhone where a mom can put a little piece of otoscope in a kid's ear and it goes right to the pediatrician. I mean, imagine how much time that saves for the mom and the kid and the doctor to do that. I hope that makes it all the way into other parts of medicine, too, where we can almost touch the patient through the device. I would really incentivize that if I was a secretary. On a more grassroots level, I think we have too much emphasis on the hospital-based patient because a lot of the finances of practice come from hospitals as opposed to prevention. So I think simple things like giving patients medications that they need, generic medications that they need would be a huge step to improving medical care too, because so much time is spent by patients just picking up prescriptions, talking to doctors about prescriptions, driving to the pharmacy, going to the ER to get prescriptions. So small things like that help patients get through the day could dramatically improve our long-term outcomes in medicine. So having access to the physician is the key, or having access to your medications is the key to preventing expensive care. Because right now, it's hard to get in touch with a doctor.
Right.
It's very difficult other than calling one number, waiting for someone to call you back. It's very doctor-centered or hospital-centered. That's changing now with electronic medical records and the ability to email and there's doctor on demand in small patches is changing. But there's no global push to it yet because there's simply no compensation mechanisms yet to reward that. We're rewarded now for the care we provide, not the prevention we provide. And until that paradigm shifts, we're going to have some problems going forward. I'm sure you might have heard the statistic, but there's basically 10,000 baby boomers converting into Medicare every day.
Oh, wow.
Okay, turning 65 every day for the next 15 years. So imagine the healthcare burden that's going to provide, or going to cost, how much that's going to burden the system going forward with the same number of doctors coming out every year, or even fewer coming out. And that's where we're really going to see a lot of stress on the system as older patients come out who are more functional and viable and need access, but are living longer. They're living a lot longer. I would recommend one book that I've been reading currently. It's called Being Mortal. Okay, it's written by
Atul Gawande.
It is. I haven't finished it yet. I'm about 2/3 of the way through, but it's some of the stuff I see every day. But the way he's put it in words really hits home. And as any aspiring medical student or resident or physician in practice, I think it really can shape the way you think about where you're going, or where you're going, whether you're done or whether you're starting. And it can shape the way your thoughts are shaped. It'll shape the way you think, which is what we need to do a better job of as teachers. And it's not all about more tests. It's about the right test, the right time, or holding off on a test at the right time.
Yeah.
By knowing the patient. And I think we need to get better at that as a healthcare system to provide better care for our patients and the citizens of this country.
I'm glad you mentioned that. Dr. Gawande has been a role model of mine since before even college, essentially. He's been writing books for years, better notes on a surgeon's performance. The big paradigm shifting one for me was the Checklist Manifesto, and how systemized care can start to remove some of the human error components so that we can start focusing on the other parts of hospital infections that, just getting out of the way, the basic problems. I also need to read Being Mortal. I'm glad you're through it. But that is literally, Dean Mitchell here at Georgetown Medical School, the only book that he has essentially purchased for the entire school and distributed by ebook to all the students was this book by Dr. Gawande. So.
Well, I'm about to make this a mandatory reading for any of my medical students and residents going forward, because I think, as we sit there in the trenches trying to decide what to do every day, we sometimes lose touch with the patient in front of us. So if you have an older patient, the focus may be not getting them 2 new knees and a pacemaker and this and that. It may be getting through the day so they can have quality of life, as opposed to more things done in more quantity but less quality. It's a slippery slope, but if we don't even consider it in the equation, we're always going to overdo it, and not always in the best interest of the patient. So I think medicine is slowly adopting that reasoning. It may be for reasons that the system's going broke, and if that's what's driving it, that's fine. But whatever way it gets driven is fine. And great books like this, and people in each hospital, there's always someone who thinks like that in every hospital. But Dr. Gawande's, ability to write it down and get it out there is really amazing. But what he's saying happens in hospitals, and there's always those voices of reason. And right now, those voices are getting more traction, as opposed to before, where they were just being drowned out by, you don't want to, we have to do everything. No, sometimes doing less is everything. Right. Sometimes not doing something is more. And I always share with my students, it takes a lot longer to think and actually do nothing than to do something. So if you sit down and contemplate the whole case and decide you're not going to do something, that sometimes took a lot more time than just clicking a box to order another test. And that's where we have to get to, in our world now. But the time pressures don't allow us always to do that. So I think I hope that changes. I'm hoping that'll change in the next, maybe not 2 years, but it may take longer. But while I'm in practice, I hope at some point, that's what we're talking about.
Well, it's good to bring it back to the long-term vision. Bill Gates used to say that, people always overestimate what will happen in the next 2 years, but underestimate what could happen in the next 10 years. So if we set those longer-term goals and are able to work towards them, and you're right, I'm glad we have, thought leaders like Dr. Gawande in the field, because we can talk about innovation, technological innovation and efficiency gains all day. But if we don't have those voices of reason saying what is happening to the patient in each of these scenarios and making sure they get the best out of it, that would be a sad part to lose. And doctors have gotten in trouble for saying things like this before. I'm curious, have you also read The House of God from the 70s? He had to use a pen name at the time when he published it.
Oh, you're right. And the good, the doctors have such sometimes internal fears about medical legal fears, or there's sometimes religious components to drive decision making, and how much how to interpret life, or what is life? Is all life every day the most important thing, or is quality more important? These are those debates you get into every day, and people's personal views do influence how they take care of patients. So, and again, that's why it's important to get everybody's opinion and see how we're going to do it and how we should do it. But it has to be considered. The patient themselves has to be considered in every decision, and giving them the autonomy to decide, and also helping them decide is very important. Not just giving them options without guidance, I think is not the right way to approach some of these complicated cases. If you go into a field and don't know anything about something, I use the example of my students about going to a mechanic and saying, and the mechanic would tell you, listen, you can do this, 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 or this. What do we always ask them? What would you do? Do I really need to do that?
Right.
Do I really need to spend $3,000 on my car? Or should I just ride this out? And as physicians, we can't escape that. We need to be part of that decision-making process. Not telling you what to do, but using our experiences with the patient, saying, my experience, this might not be the best thing to do, or this is worth the risk. You might not want to do it. So both ways. But we have to take responsibility in that process. I don't like when I see people step back from that and say, what do you want to do, patient? Hey, that's not really fair. The patient doesn't have the experiences that you have, right, to make that decision and make an informed decision sometimes. And sometimes patients make decisions that may not be in the best decision. And you go with it, but you can still help them get through that and temper expectations, or tell them what may or may not happen. I know you've decided to do this. This is what my concerns are. We can hope for the best outcomes, but these are what I'm concerned about along the way. And that way, it gives you some credibility when, if it does happen, you did go with them, but you explained to them what might happen. You're not kiboshing the plan, but you're also being realistic. And I think we have to get better at that.
And it's unique. It would be so much easier to fall at an extreme end of the decision-making spectrum on 100% patient autonomy or 100% physician paternalism, or whatever people want to call the Hippocratic model. But essentially, rather than being a total subject or a total domineer to the patient, you actually become a teammate with them in those decisions. So articulated very well. Very fun questions. So hypothetically, if you suddenly had $10 million available, knowing what you know in the field, what would you invest in? You can pick a single trend in medicine or a company.
Ooh, that's a good one. I would focus on something that takes care of the elderly, as I alluded to earlier. Things that are going to help people live better and live longer independently. So I don't know what that would be. For example, in my own world of home-based dialysis, I think that's a huge area coming up as we see people living longer and wanting to be home and more independent. I think the home-based dialysis world is going to explode and is already getting bigger slowly. I think that's a huge thing. I'm trying to think of something else, something Shark Tankish. I'm not sure what else. I think anything that focuses on independent living that's not a nursing home is going to be big. Something that promotes that sort of business. I don't know of a specific company, but I'll leave it at that, I guess.
Sure. Does someone like you actually have time to watch the show? Do you enjoy Shark Tank?
Oh yeah, I'll get my kids to watch it. I said, "Well, you want to?" see one of you guys on Shark Tank one day. I watch it in bits and pieces here. They're not a regular viewer, but if I'm flipping the channels and I catch it, I certainly will watch it for sure.
Yeah, I love it too. On the most recent episode, there was actually a medical student on there who's taking a year off to do his MBA at Yale. And he got like 2,400 on the SAT at one point. So now he's building out this online business to teach other people how to do it. So I immediately sent it to my sister, who is hoping to get into business, and said, check this out.
Yeah, why not? Why not? I mean, it's an amazing show. I think it really makes you want to. Everybody, when you watch it, you think of your own inventions immediately right afterwards. Mm-hmm. I wonder if Mark Cuban's going to join me and do this deal.
Yeah, absolutely. So next question: pick one buzzword in the medical profession right now. Any buzzword you love or hate, and what should people know about it?
Oh man, let's see. Buzzword. I think palliative care is a buzzword that has a weird connotation. Let me take that back. I think the word hospice is overused and not understood at all in the world of medicine.
Okay.
Hospice has this terrible definition of death, meaning when you go in hospice, you die, as opposed to living with comfort and dignity. So I think that one word needs a makeover and maybe needs to change on that side. We've been talking a lot about independence in older patients. I think that's a word that needs a total makeover.
Independence over hospice.
Yeah, something like that. I don't know what I would reword it, but hospice, just people don't understand what that means. So, for example, you got a couple of medical illnesses, and you're not going to ever get cured from them. Mm-hmm. You ought to consider care that keeps you happy and healthy at home, as opposed to going back to the hospital for everything. And when you tell a patient hospice right now, all they mean is, "Oh, I'm going to die," and that's not what the word really means.
Let's talk about data for a minute. So we've talked about a few things in terms of just the volume of patients that you see, the amount of charts you look at on a daily basis. Something that I like to discuss with people is the concept of vanity metrics, and whether you're doing organizational management and looking at a system, or you're running a podcast, and if your goal is to get more listeners, then it's kind of silly to just look at people who come visit your website, but then never actually listen to a podcast. So what do you feel like data-wise in your field people pay too much attention to that is just a vanity metric? And what are the data points that you really wish people either in dialysis care or nephrology could really hone in on?
Good question. So I think a lot of it's touched in the book we've alluded to a couple of times. Right now we've become, from the checklist manifesto, which saves lives and helps people not have bad outcomes in surgery. Right now, hospital care is driven by checklists of everything. Did you order a pneumonia shot? Did you click off smoking cessation? Did you refer the patient to diabetes education? Did you do this? Did you do that? With no real understanding if that's translating into better care. No real understanding if that means there's less hospitalization, less death, less complications, because that's how hospitals get reimbursed, by clicking off boxes that say they did all these things. So I think all those metrics are very dangerous because they're misleading. So that's one thing I think really needs to be reconsidered. The other thing is this grading system that we're all dealing with as physicians. Because right now, you get evaluated on multiple levels, from patients, from hospitals. And in an effort to keep your score good, whether it be a dialysis center or the dialysis doctor or a primary care doctor, you might have doctors or systems not taking care of patients because it goes into the denominator and it impacts their overall, how they look on the web. Okay, I think no hospital will ever do that to a patient, but what I'm saying is that it goes into the back of your mind, because it's like, all of a sudden, why would I take on this sick somebody? Because they're going to just drag down my numbers. Because there's no asterisks on the websites, or the asterisks, there's just data. Mm-hmm. So, like, for example, if you had to have surgery with a doctor who had a 3% complication rate versus one that had a 1% complication rate, I think most would say, we'll take the one with the lower complication rate. But what's lost in that equation is what's the numerator and what's the denominator. So if you have a doctor who has 5 times as many cases as another doctor, that means they're probably taking on more sick patients, or they have more volume, and they probably may have a little more complications. You see what I mean? Mm-hmm. So I think a lot of this data that we're getting doesn't help the consumer nor the system make informed decisions. So what metrics should be measured is difficult, but more on a population level, I think. How many patients with this condition are being hospitalized? In your cohort of patients, in my world of chronic kidney disease and dialysis, how many of my dialysis patients end up in the hospital every month? How many of them pass away in a year? How many of them get transplanted? It's much more meaningful to me than the nitty-gritty data of how many people got a flu shot, or how many people got a smoking cessation referral. I don't know if that's really equating into better outcomes. So I wish the data would be driven more on a population level and more on an absolute reduction level. So this year you had this many patients who got sick. Next year your percentage went down by 20% or 25% or 30%. That's much more valuable to me as a physician or as a hospital than you telling me that every year I got to have 90% of people meet this goal.
Right.
So it's like having kids getting A's in school but not making it into college or graduate school. Okay, or getting A's in school.
That would be a vanity metric.
Right. You get all these A's but don't do well on a standardized test. You know, are those A's really meaningful? And vice versa.
Yeah.
You got all C's but you got A's, the ACT, SAT. You know, are those grades really meaningful metrics? I don't think so. So I think if we could find a way to measure the endpoint better than the entry point better. We're doing a lot of entry point data measurements in medicine as opposed to other things. So the hospital spends a lot of time and energy on all these patient safety measures, which are very important, but are they changing outcomes? I don't know. With limited resources, limited time, where should we spend our time and energy to take care of patients? Should we spend time and money on prevention, more about diabetes prevention than having better wound care for the foot ulcer for diabetes? You know? To me, it should be the other way around, but you know, that's not built into the system right now. You know, it's about the end. It's the end result and not the upfront result sometimes too.
And as we've talked about, government can be a slow learner. Thankfully, there are companies in that space that are emphasizing outcomes. It was, just interesting for me to hear about in the past couple of years, Omeda Health. For a guy to work at Google for a couple of years, he gets into Harvard Medical School and Harvard Business School, drops out in the first year, which I thought would be crazy. But then 5 years later, he has a company worth over $2 billion, and they don't even collect money from patients, as far as I understand their business model, until they have eliminated specific pre-diabetes measures, help them lose a certain amount of weight, and once those outcomes are reached, the patients pay them based on that.
Wow. That's the forward thinking we need, because that's where the downstream costs go down. Mm-hmm. Right now, we're not affecting the downstream costs in a way we should be. And really, I think, as we alluded to a couple of times, it's the way hospital systems are paid right now. They're not paid for prevention. That's slowly entering the world, but it's not in there in a meaningful way yet to make people wholesale change the way they spend the money they get. So right now, we're still a admission-based business. So unless patients get admitted to the hospital, you're not making any money.
Right.
The hospital is driven by admissions, because each individual hospital has to survive. Whereas the system will be broke that way, because every hospital in every city in every part of this country is admitting patients left and right, and when they need things done, that's where they're getting their compensation from, because that's the model that they've been given. If they're given a different model, you'll see a change overnight, in a meaningful way. And that is happening slowly. I mean, it's not happening at all. It's just happening in more innovative, in the big centers now, in the big Mayo clinics of the world, and those places it's happening, but it hasn't trickled down to the other areas just yet. And I hope that it does.
In the sake of wrapping up here, what is the one thing, if people can listen to an hour-long podcast, but then they're going to go to the library and hit the books again, have to study a lot of stuff. If they could take away just one thing or piece of advice from this interview, what would you want it to be?
I would want it to be that if you're going to be a physician in your lifetime, and that's when your job, you need to don't be complacent. Don't take that first job and think that's where you're going to work forever. You have to remember this is a business. Medicine is a business like any other business, a restaurant, a shop, a design for anything. Mm-hmm. And if you don't play an active role in that business, know how the finances of that business work, you're behind the eight ball. Well, one of my colleagues said, we basically have become commodities, physicians. We're no longer in charge of what we're doing. We're asked to do something, we get compensated well for it, but we're not in control of our own destiny. And we still have that power and control and the ability to do that if we want it. But it doesn't come easy, and physicians are the drivers of healthcare. We're the head of every team that we're on. Mm-hmm. And if we don't take that responsibility seriously or know that that's our role, we can't leverage that to get other things done. And we can't make our patients better. So we got to quit complaining about administration and who's running the show, because the doctors really do have the power to control these things if they want to. And I don't know if we're doing a good enough job just yet. But I think as more people get out there, if they take that away from this podcast, I think that'd be the take-home message, and not to be afraid to go out on your own. There's still opportunities to do that.
Perfect. Wonderful. And so we already touched on, YouTube channel, Prezi. I'll post some of those resources so people can access them. Thank you for sharing those. Do you have any asks for them or want to tell us about anywhere else they can find out about you online and your work?
Basically, I have the YouTube channel, youtube.com. Renal Whisperer is all one word, is the YouTube channel. Other than that, nothing at this point. That's where I am right now. I'm at NOLA Doctor on Twitter. So if they want to communicate that way, that's also another way. NOLA Doctor, NOLADOCTOR. I don't post a whole lot over there, but I do have that handle. So if anybody wants to start, I'd be happy to start getting more involved in that way. But those are my two ways to get some information.
Perfect. Will do. Well, we'll wrap it up there. Thank you so much for your time. Let you get back to your teenagers and your family. Thanks again for your time.
Thank you. Thank you, Joshua.
Well, that's a wrap for another episode of The Ultimate Doctor. For more interviews with awesome guests, just hit subscribe and then check out the bonus highlights at theultimatedoctor.com. Until next time, thank you for listening.